Good afternoon, everyone. Welcome to our cardio webinar, Race and the Clinical Management of Cardiovascular Health. I'm Dr. Michael Constant of Case Western Reserve University School of Medicine, and I'm pleased to serve as the principal investigator of the Ohio Cardiovascular and Diabetes Health Collaborative, also known as Cardio. With me today is Dr. Sherry Bolin, co-principal investigator of Cardio, also from Case Western Reserve University. Founded in 2017, Cardio's mission is to improve cardiovascular and diabetes health outcomes and eliminate health disparities in Ohio's Medicaid population. Cardio brings together Ohio's 7 medical schools to identify, produce, and disseminate evidence-based cardiovascular and diabetes best practices to primary care teams. To learn more about the collaborative and to access our online repository of best practices, please visit our website, cardio.org. I would like to acknowledge and thank our sponsor, the Ohio Department of Medicaid, and our administrative partner, the Ohio Colleges of Medicine Government Resources Center. I would also like to recognize the partnership of Ohio's 7 medical schools who contribute to make the Cardio Collaborative a success. And with that, I will now turn the program over to Dr. Bolin.
Thanks, Mike. So just a few logistics. If you are planning to get CME afterward, that you do need to actually register for the webinar. So just be aware of that. We mentioned the CME. We'll be sending a separate survey email for the CME survey evaluation, and that will need to be completed by Friday, April 15th. And you'll see that email coming from Kathy Sullivan. In terms of disclosures, we have one disclosure by Dr. Taylor with a commercial interest, but it is not really related to our topic today for discussion. And as we discuss disclosures and acknowledgements, Mike mentioned how we are funded by Ohio Department of Medicaid, and that the grant is also administered by the Ohio Colleges of Medicine Government Resource Center. But the views for this presentation are really those of the presenters and do not represent the views of the state of Ohio or any federal Medicaid programs. So getting into the meat, our objectives today are really to describe how the construct of race has been applied in clinical care of cardiovascular health. We'll review recent changes in academic and clinical discourse on the use of the construct of race in clinical guidelines, and describe how the historical context and recent changes on the construct of race in clinical guidelines impact primary care practice. This is our agenda. We'll have some introductory remarks from Ohio Department of Medicaid, Dr. Applegate. We'll have Dr. Taylor as our keynote talk about race and the clinical management of cardiovascular health. We'll have many wonderful panelists and our moderator to talk about this topic today. I'm so very excited for that discussion. And then we'll have some Q&A at the end. And these are our wonderful speakers, panelists, and moderators today. Thank you all for joining. We will be introducing you as we go through the program. So with that, I will start with Dr. Applegate, who will start off with some introductory remarks for us. And she serves as the medical director for the Ohio Department of Medicaid and is responsible for improving health outcomes for Medicaid enrollees across the state. She is a fellow of both the American Academy of Pediatrics and the American College of Physicians, and has been caring for infants, elders, and families for over 25 years. Her special interests include the application of clinical principles and quality improvement science to health systems to improve the quality of healthcare, health outcomes, and equity. She has been instrumental in driving change in perinatal health, safer opioid prescribing, and integrating behavioral health care. And her more recent work has been focused on effective population health management, including harnessing opportunities related to paying for value in healthcare. So thank you for joining us today, and I'll turn it over to you.
Thank you very much. It's my pleasure to be with all of you again today. This has been one of the efforts that I see perhaps some of the most potential for as we try to bridge the gap between clinical practice research and real-world improvements that can be measured at a population level at scale. What I'd like to describe to you is that the Department of Medicaid is embarking on a next generation of what managed care and payers can do. So often when we do our research efforts and in our clinical practice, we really think it's just the doctors and nurses and social workers and the patients. But what I'd like to suggest to you is that the payers offer an infrastructure that can help us get to a better place. So often research is focused on implementing, discovering, describing, and implementing best clinical practice. What I'd like to challenge you to do is to think about what best payer practice would look like to help advance your goals. So why do we care about this? What you see here is a sort of a diagram of our quality strategy for the Department of Medicaid. And it's a surprise to some people to realize the breadth and variety of people that are actually covered by our particular program in offering and covering health services. What you see is that we actually have healthy kids and grown-ups. That's a surprise. You mentioned already our work around infants and children. We cover more than half of the deliveries in the state. We also have about half of our individuals who have behavioral health challenges. And what most people think of are individuals who have multiple chronic conditions, often with roots in the social determinants of health. We also are an important funder of nursing facility and home and community-based services. What we have done here is we've articulated the goals. We don't just want to keep paying for services. We want to make people better. And with that goal in mind, you notice at the top right-hand side, we've called out equity as one of the most important goals that we have. Many of our members from minority communities are different from the average patient. And so something that works for an average person may not work for everyone. And this has become quite clear in the last several years in particular. So what we would like to do with you is have a different conversation. What you see in the center here are many of the structural changes we're making to have a system that works better for people in our program. So the system just does not work well for them. And you'll probably describe this in some detail. Why do we care about it so much? Well, we recognize that Ohio's population might be 12 or 13% Black, for example, but in the Medicaid program, Black families are 29% of the people that we cover. So we have this extra responsibility in trying to get everybody better, not just the average person, but everybody. So hats off to you for taking the topic of race, kind of putting it on the table front and center and having a discussion about how it is we can do a better job. Everything from training to language to attitudes. The other thing that I'll submit to you is I think it's going to take all of us, no matter what the color of our skin and our place in society and privilege, lack of privilege, where we live, it's going to take all of us to put all our ideas on the table to actually try to address this. So we've arrived this way over years of different kinds of policies. And I think just shining a light on it in terms of helping everybody be as healthy as they can be is really a wonderful way for us to try to advance outcomes for everyone. So I do want to challenge you to think about payers in a positive way. I think in your group, you've noticed that we've tried to bring all of our managed care organizations together with one voice to address the needs and to listen to the concerns, not just from all of you, but also directly from members in our program as well. So I thank you for this. We want to partner with you, not just in terms of funding, but also in terms of how we work with our managed care organizations to do a better job for everybody. So with those remarks, I'll be listening very intently and invite you to continue to have these kinds of open conversations with us. So thank you in advance, all of you.
Thank you, Dr. Applegate, for those introductory remarks and getting us started. And I'm going to introduce now Dr. Gagliotti, who will serve as our moderator today. She is a family physician and associate professor at the Population Health Research Institute at the Metro Health System and the Center for Community Health Integration at Case Western Reserve University. She is a senior strategic advisor and associate professor at the National Center for Primary Care and an affiliate faculty member at the Cardiovascular Research Institute at Morehouse School of Medicine in Atlanta, Georgia. So welcome, Dr. Gagliotti.
Thanks very much, Dr. Bolin. It's great to be here, and I am excited that I have the pleasure of introducing our keynote speaker, Dr. Herman Taylor. Dr. Taylor is the endowed professor and director of the Cardiovascular Research Institute at Morehouse School of Medicine, overseeing a diverse portfolio of cardiovascular research involving multiple interdisciplinary teams. Previously, he was the founding director of the NIH's landmark study of African American heart health and disease, the Jackson Heart Study, and the broad network of training programs, research centers, and collaborations that the study comprises. As PI, director, and steering committee chairman, he established and sustained a coalition that is the world's foremost repository of multi-layered data on African American heart health, and which continues today under the leadership of outstanding scientists, clinicians, and educators. Frequently cited as one of America's best cardiologists, Dr. Taylor has also been the American Heart Association's Physician of the Year, and in 2020 was among the 100 newest members elected to the National Academy of Medicine. Dr. Taylor's current work at Morehouse School of Medicine continues as a focus on the advancement of health equity. Through projects funded by the NSF, NIH, AHA, 23andMe, Google, Apple, the Truist Foundation, and the NFL Players Association, and others, he has led the CVRI to broaden its traditional focus on biomedical basic science and embrace an expanding use of the tools of clinical medicine, multiomics, mHealth applications, wearable and off-body sensors, in combination with social epidemiology to more fully understand the sources of and solutions to health disparity and inequity. Observational intervention studies featuring mobile apps co-created with minority youth, coupled with pipeline initiatives that create academic and economic opportunities among them. He has lectured internationally and given expert testimony to Senate and House committees and the U.S. Commission on Civil Rights on Health Disparities and Equity. He is a graduate of Princeton University, Harvard Medical School, and the Harvard Chan School of Public Health, and holds adjunct professorships at Emory School of Medicine and the Harvard Chan School of Public Health. Dr. Taylor, we're very excited to have you, and I will turn it over to you.
Thank you very much, and for that very generous introduction. It's a great pleasure to be here with the finest physicians and providers in Ohio. And of course, we still claim Dr. Gagliotti as one of our own down here in Georgia as well. It's you guys are tremendously blessed to have her among you. We continue our collaboration and look forward to many fruits in the coming days, weeks, and years. We have some important business to discuss today in a very short amount of time. And I hope to, by sticking somewhat closely to my notes, be disciplined in my use of that time so that we can hear from some really fantastic experts who are in the throes of grappling with some of these really critical issues about race, how we detect disease, how we prevent disease, how we manage it, and the importance of race in that overall picture. You know, we're in this era where we're trying to reach towards precision medicine. What does race mean in this era? Does that improve our precision, or does it somehow cloud some of the key issues? A brief further word about who we are here at Morehouse. We consider ourselves leaders in the creation and advancement of health equity. That is our DNA. If you're looking for what motivates all of us for being here, why we get up in the morning here at Morehouse, it's this: to move towards perhaps a somewhat utopian notion of everyone having what they need, when they need it, and the amount they need in order to maintain health equity. And in the Cardiovascular Research Institute, to be more specific of the part of the institution, the part of Morehouse School of Medicine that I actually lead, we try to marshal all those things that Ann mentioned in the introduction towards health equity in particular. And we have been fortunate to garner the support of a variety of diverse funding agencies and other supporters. My brief remarks will track generally along these lines. That is talking a bit about race and racism, the disparities, and some of the early insights of the Jackson Heart Study that I think will shock no one, but are important to review. We'll talk about the construct of race in cardiovascular disease and what may seem to some out of place. We're going to at least touch on a notion of resilience, which I think is important and underemphasized in the African American population in particular. A lot of my remarks will be generalizable to other minority groups. I will, in my remarks, however, focus on African Americans who have been the focus of my research in the years of my career. So what is race? We call it a social construct because it quite simply is a category that society assigns you based on the way you look. Everybody understands the qualifications for being called either Black or white, even if they can't articulate them. You know, it's like that Supreme Court justice said about another topic, you know it when you see it. And the interesting thing is that we make traditionally, all sorts of connections with how people look to what they are, not only character, but also biology. And nothing could be more fallacious for us to do, particularly as people who are concerned about science, people who are focused on health. Racism, which we'll define further, has an impact on health and health outcomes. This is proven science. This is really beyond debate at this point. And in the United States, we have a persistent but inevitable disparities that can be traced to that reaction to race or racism that have been troubling and intractable to date. But there's nothing, I believe, that says that they are inevitable. What is racism? Again, it's one of those terms that carries such weight in America that it often takes on this sensationalist character. And it really pushes people to engage in emotional exchanges rather than analytical scientific discourse. But I ask you to consider this definition by a former member of the Cardiovascular Research Institute, I'm proud to say, Dr. Kamara Jones. Racism is a system of power that structures opportunity, housing, jobs, justice, etc., and assigns value, worth, or unworth, full of potential or full of menace, based on so-called race, the social interpretation of how we look. Kamara goes on to point out three major impacts that there results from these racist reactions to racial identity: unfair disadvantage for some, unfair advantage for others, and a waste of human resources. And we can talk about how that waste manifests in many ways, and perhaps we'll get into that in the panel. You know, we think of race and racism often in some of these dramatic instances illustrated in this collage. And of course, this is an important aspect of race. Pictured here, you see demonstrations, you see horrific lynching, you see a scene from the Tuskegee syphilis study where people were deceived into thinking that the lumbar punctures they got every year were therapeutic, not totally speculative and experimental. These are the types of racism that we can see and be appalled at, things that we ourselves would never be a part of. But that's the tip of the racism iceberg. If you look at this with a little bit more rigor, you'll see that there are racialized structures that African Americans have to throw themselves against on an almost daily basis. And in some instances, there are major occurrences in life across the life course that really are determinant for economic outcomes, the derivative health outcomes, and other things that are really critically important to where you find that patient sitting in your office is on the occasion of your office visit. Quickly, some enduring racialized structures, just as a reminder: residential segregation. One of the most profound influences on race relations and race socioeconomic status to date. We don't have time to go into a lot of detail about how that derives, but where you live determines not only what you're exposed to physically, what kind of transportation you can or cannot access, what kind of job, and what your upward mobility in those jobs be, and of course, the wealth of your family is so often determined in very large part by the wealth of the real estate that you own or do not own. These other bulleted items, disenfranchisement, by very actively debated now, issues surrounding voter suppression that have derivative effects that dramatically can impact whether or not there is policy to protect these vulnerable populations, whether it's about streets and sewer and water, or whether it's about something even less concrete, but equally impactful. Healthcare inequities, educational inequity, underfunding of all of the structures that conspire to wind up underfunding millions of African-American children, underfunding their education at every level, that has very direct impact on health down the road. Dietary insecurities, where access to good food is, and so on. I think most of you in the audience have at least some notion that race, where you live, what your income is, these things all work together to put African-American health at risk. Interpersonal racist encounters, of course, again, are the things we think of when we talk about race. And those are not unimportant. They do acutely, and this has been shown in study after study, they stimulate inflammatory responses, neurohormonal derangement, and acute activation of the HPA and sympathetic nervous system. These things are not good or healthy, and cumulatively can add to health disadvantage for minority populations. So why is a guy like me, an invasive cardiologist by training, talking about these issues? This seems a bit far afield. Should not be talking about hemodynamics and coronary artery stenoses and so forth. Those are important things. But I submit to you, and I think there's a substantial literature that has emerged over the last 30 years to suggest that these things are very directly related to less race, but much more the societal reaction to racial identity and the stressors that those exposures carry. We looked at this early in the Jackson Heart Study, and Jackson Heart Study, as said in the introduction, continues today under very able leadership in Jackson, Mississippi. In the Jackson Heart Study, the whole enterprise emerged at a moment in American medical history where we had significant deficits in knowledge about African-American health and disease, particularly cardiovascular. We also had a pretty wary population in terms of African-Americans being interested or willing to participate in research. And we suffered a real dearth in the African-American professionals who were servicing that population, or Americans in general. So we had a big charge, and we audaciously tried to embrace them all. But what I'll talk about briefly is some of the early work that showed just how important social determinants, psychosocial factors were in the genesis of bad health. First, let me set the stage. And the irony for the development of the Jackson Heart Study is that what we found in the middle of what some cardiologists refer to, somewhat self-congratulatory in manner, refer to as the golden age of cardiology. That latter half of the 20th century, when all of the cardiovascular health statistics were trending in the right way, with the possible exception of heart failure, but that's another story. But overall, cardiovascular disease mortality was going down, and going down dramatically. Obviously, a major public health success story. In the midst of that, it was also observed that there was a yawning gulf between the health of African Americans and the quote unquote average American. Here depicted graphically, you see the disparity that emerges between Black men in Mississippi and white men nationally. And you see that if you look carefully at these data, and look at the beginning of the data included in this particular slide, which is around 1976, and the end, which is around 2005. If you look at that, you'll see that for African-American men, while in Mississippi, while the men nationally were enjoying the fruits of this golden age of cardiology, that this number in 76 and this number for mortality in 2005 were absolutely unchanged. 30 years, a full generation by some counts, 30 years of stagnation, 30 years during which the fruits of the vast investment in cardiovascular health by the research enterprise had yielded very little for African Americans. We found in the Jackson Heart study, again, going back to the point I was raising earlier, that social determinants are an important part of this equation. Hypertension is the leading cause or leading risk factor for the development of cardiovascular disease worldwide, and particularly so among African Americans and for all Americans, in fact. And what we found early on, when only cross-sectional data was available, was that the perception of discrimination was associated in a cross-sectional analysis with the likelihood of someone having high blood pressure. This was important and highly suggestive of a connection between the perception of discrimination and development of high blood pressure. Later on, as time has gone by, we have incidence data that is looking at the longitudinal development of high blood pressure in people who did not have high blood pressure at first. This simply shows that among people who reported high levels of discrimination experiences, that they were 34 to 49% more likely to develop high blood pressure across their lifespan than those who did not have such experiences, or at least reported low levels of such experiences. And here you see the term lifetime discrimination. That refers to major affronts, if you will, such as problems obtaining loans for housing or for education, discrimination in employment, other opportunities being denied, hostility from law enforcement on a chronic basis. Those experiences get under the skin and produce pathology, such as the leading cause of cardiovascular disease worldwide. So if you consider even briefly the exposures, the experiences of African Americans in the United States for many years, W.B. Du Bois' assertion here is that we shouldn't be surprised. No one should be surprised at disparities. And I think it behooves us all to really consider in many, many ways the people who are suffering from excess levels of diabetes, obesity, hypertension, cardiovascular disease are in fact suffering as victims of an array of environmental exposures, the behaviors that people use to cope with those exposures, and that we need to have the sensitivity to understand that some things that they have experienced, and even some of the things that we may recommend, are beyond their immediate control, or the effort to overcome those is truly Herculean. It is not an easy thing to ask somebody who doesn't know where a supermarket is with the right foods that you're recommending or can't get to it. It's not an easy thing to expect them to improve their diet. So again, going back to the long reach of chronic racism, I think it's important for us to keep in mind that the contextual and individual, social, behavioral, et cetera, influences. Add to that genetic and epigenetic changes that may have occurred over the course of exposures to a very negative environment, or an environment that contains a lot of corrosive and toxic elements, that these things do indeed get under the skin. They can lead to epigenetic changes that can even be passed on from one generation to the next. We're just beginning to grapple with and understand some of these influences. There's a huge number. The data supporting them is accumulating. And it really brings us to this place where we talk about precision medicine, but it is such a difficult thing to achieve. And we have to be mindful of the fact that a lot of what we're attempting, a lot of what will be discussed in the panel to follow, is the sum of our attempts at grappling with all of the nuance, all of the difficult to categorize, document, list influences that sum up to bring someone to ill health. Our equations, our guidelines, and so forth are really our struggle to try to embrace the difficulties that race in our society introduce into the whole matter of health. and in particular, the health of minorities. And one important thing I think to consider as we consider all of these multiple influences on African Americans is a very simple point that I think for some probably it will seem like it's patently obvious, but I think it needs to be mentioned, and that's this. All African Americans are not the same. The heterogeneity of African Americans is often unappreciated. The African American health status overall is, I think by many, seen to be negative. If you were to quickly summarize, if you were to close your eyes and ask the question, what's your vision of African American health in general, your response quite likely would be one that is negative, that is mostly characterized by a depressed health status, a foreshortened lifespan. I want to assert in this slide that there's another side to the story, that in fact, there are many examples of African Americans who live long lives, who thrive, and who do quite well despite all of the things that are arrayed against them and conspire to produce ill health. I will summarize that concept as one of resilience. And I think that it's important to keep this in mind because we're dealing one by one with individuals when we meet people in our offices. But I think the notion of resilience bears mentioning because I believe that there are important pathways, important insights that may be unexplored if we don't consider for a moment that the dominant story for African American health across the last 400 years, the dominant story is one of survival against incredible odds. In 1899, a Dr. Hoffman, a leading statistician of the day, a man who eventually would predict the connection between tobacco smoke and lung cancer. Now, this was 1899, 65 years before the Surgeon General made the same prediction. So he was not a lightweight. But this gentleman suggested that African American health was so long that was in such trouble that the African American group would not survive the century. Obviously, that did not happen. The importance here, the point I want to leave you with, is that it is critical to consider the individual, to understand in the midst of everything that looks negative about their exposures and their current status, that they are indeed not a demographic, but an individual. And with that attitude, I think we do well to care for our patients with sensitivity and empathy. I believe I'm over time, and I will stop my remarks here and save further comment for the panel. Thank you very much.
Thank you so much, Dr. Taylor, for that wonderful keynote. I have the pleasure now to introduce our panelists. Our first panelist, Dr. Cynthia Delgado, is an associate professor of medicine with the San Francisco Veterans Affairs Healthcare System and University of California, San Francisco. She's the associate chief of nephrology for clinical operations and the director of the dialysis program for the San Francisco VA Health System. She's the chair of the Diversity and Inclusion Committee for the American Society of Nephrology and has served as co-chair of the NKF-ASN task force on reassessing the inclusion of race in diagnosing kidney disease. She is a recognized international expert on functional status, frailty, body composition, quality of life, and related outcomes among individuals with chronic kidney disease. Welcome, Dr. Delgado. Dr. Lou Edgy is an accomplished family physician recognized as the Ohio Academy of Family Physicians 2012 Family Physician of the Year, as well as receiving the 2022 Dr. Martin Luther King Jr. Humanitarian Award. Dr. Edgy has served as a family medicine program director at the University of Michigan, as well as department chair and chief of staff at St. Luke's Hospital. Currently, she serves as the Dean of Graduate Medical Education at the University of Cincinnati Medical Center. Dr. Edgy is an accomplished in the areas of health professions education and health policy. Welcome, Dr. Edgy. And finally, Dr. Leon McDougall is a family physician and the first African-American professor with tenure in the Ohio State University Department of Family Medicine. He is the first chief diversity officer for the OSU Wexner Medical Center. Dr. McDougall has a Master of Public Health degree from the University of Michigan School of Public Health He has served as the chair for the AAMC Group on Diversity and Inclusion, as well as on the NCAA Medical Advisory Group. Dr. McDougall has been recognized nationally for clinical excellence, and his research career has been focused on eliminating health disparities and increasing diversity of the biomedical and behavioral science workforce. Welcome, Dr. McDougall. And thank you to all of the panelists for being here. The first question will go to you, Dr. Edgy. In reflecting on Dr. Taylor's comments, can you further discuss the importance of distinguishing health impacts of racism versus race, and why that distinction is so important to advance health equity in the realms of primary care practice and population health?
Thank you for that excellent question, and thank you, Dr. Taylor, for an incredible program. I recall being at the 2018 American Medical Association annual meeting where we declared that racism is a public health issue. And it was pivotal because it supported the importance of intentionally acknowledging that racism rather than race affects life and death decisions in medicine. One example is patient prioritization for advanced cardiac therapy for heart failure. The American College of Cardiology had an excellent article in October 2020 on racial and ethnic inequalities, as well as biases in advanced heart failure therapy. We know that Black men and women are disproportionately dying from heart failure compared to their age-matched white counterparts. We also are much less likely to receive appropriate medical therapy, implantable defibrillators, left ventricular assist devices, and cardiac transplants. We also know that the social support and patient motivation are influential in the cardiac transplant selection process. Last month here at the University of Cincinnati Medical Center, as a primary care physician, I was delighted to receive an invitation from one of our cardiothoracic surgeons to attend the Cardiovascular Transplant and LVAD Patient Selection Committee meeting. And this was because I had one of my patients, a young Black male, on the list. He had been previously healthy as an athlete. He'd gotten his single J&J vaccine 2 weeks prior to his trip. And while he was at his destination airport, he became unable to handle his baggage because of shortness of breath. He subsequently was found to have non-ischemic cardiomyopathy with an EF of 10%. Subsequently, he had dense left hemiparesis and a CVA. Since then, he's been working extremely well in rehab. He is motivated and he has a rock solid support system. My presence as his family physician at that meeting was to provide the full context for the patient's life and a holistic perspective. It is collaboration and invitations like that which make a difference in population health, one patient at a time. Thank you.
Thank you, Dr. Edgy, for sharing that powerful story. Dr. Delgado, we're interested to hear from you because you led Nation's national reporting of a race-neutral clinical algorithm for eGFR. What do you feel will be the impact of this change in reporting on health equity?
Well, thank you for having me. I'm truly delighted to be here. And I agree, Dr. Taylor's talk was really just inspiring. And I will say that our work, the task force to identify an approach that would be race neutral was really an all hands on deck moment for the nephrology community and for the practice of medicine. What we hope to achieve is to increase the clarity and communication between patient and provider on risk of kidney disease, and to also clarify how we decide and what we determine are the important factors in leading patients to transplantation, dialysis, and some of the other considerations that we also examined were, the utility of medications and medication dosing and the use of race in the eGFR algorithm for deciding on things like chemotherapeutics, SGLT2 inhibitors, which are very important for cardiovascular health, and other medications that are primary in prevention of cardiovascular disease and, of course, in kidney disease. So our hope is that the removal of the race coefficient and coming up with a race neutral approach is going to help work towards improving health equity and the delivery of healthcare across the nation.
Thank you so much for those comments, Dr. Delgado, and for your important work in this space. Dr. McDougall, I know you have been a leader in developing tools for practicing clinicians to do their own work around anti-racism. Can you talk a little bit about how practicing primary care clinicians and educators can work either on the individual level, the care team level, the practice level, or at the health system level to implement anti-racist actions, and speak to why these tools are so important to advancing equity.
Thank you so much. Excellent question. My first example will connect with what Dr. Delgado helped lead. So with our anti-racism action plan and working across the medical center, in fact, on February 1st, the race correction across the medical center was eliminated. And as you know, a Black patient with a lower GFR was considered normal. And that delayed referrals to nephrologists and consideration for transplant. And that's doubly troubling because we know Black patients who are on the transplant list have to wait longer. So you have to wait longer and you get put on the list last. So thank you so much. So that's part of our anti-racism action plan for the College of Medicine and the Medical Center. In addition, we're asking our providers and learners to take the implicit association test for race, gender, and sexual orientation. And we've combined with and partnered with the Kerwin Institute on Race and Ethnicity to create a 30 to 40 minute online module for on-demand implicit bias awareness and mitigation. And over 25,000 people across the medical center have completed that. We've complemented that with classroom implicit bias mitigation. And another tool involves the 21-day anti-racism challenges, and our chancellor charged the leadership with completing the 21-day anti-racism challenge. It has been updated by Dr. Moore. Another version that's available online is the 21-day racial equity habit building challenge. So I would recommend that our audience take that challenge. In addition, Dr. Taylor spoke to the wonderful work of Dr. Kamara Jones, and to help motivate the team, I recommend that the TED Talk, the 20-minute TED Talk allegories on race and racism be viewed. And when we identify those barriers to social determinants of health, the American Academy of Family Physicians has created a wonderful resource, the AAFP Neighborhood Navigator. So I recommend that you go to that website, put in the zip code, it identifies resources. And lastly, I have a lot more to say, but I know we have limited time. It's important to have a conversation with people. And what we find with those cross-cultural communications, whereby Black people are less likely to follow the therapeutic plan, that's because the conversation is not that, it's a physician-dominated discourse. And we need to have more communication. That could be via the 15-minute hour, the BABE technique. And then lastly, workforce diversity. So those would be my recommendations. Thank you so much. Very good question.
Thank you, Dr. McDougall, and amazing work you all are doing at Ohio State, and great resources for all of us. I just want to hear your perspectives on the sort of dual importance of measuring the impact of racism on cardiovascular health outcomes while also pushing forward the science and the measurement of equity. And can you talk about some goalposts or measures or signs that we are advancing towards equity in cardiovascular health? How can we measure success in our work?
I'll pivot to the wonderful work being done by Dr. Taylor and Morehouse, College of Medicine, the Jackson study, and this research being done by Dr. Taylor provide a roadmap for us as primary care providers to improve health outcomes. He mentioned the fact that variables were being assessed to determine the impact of racism on health care. I think one method would be through the electronic medical record and fully utilizing and implementing the social determinant of health platform that is available. If not, otherwise, perhaps asking questions of our patients about barriers to equitable care, whether it be transportation, food insecurity. The Ohio State has piloted a program with the Mid-Ohio Food Bank called pharmacy with an F, whereby patients receive a prescription that they can take to local food pantries to help overcome that food insecurity that may also be present. So this is a wide area for further investigation and more in a translational way and looking at our outcomes. Those would be my initial thoughts.
Okay, I just wanted to second what Dr. McDougall said and thank him for reference to our work. And also the great comments of the other panelists have been fantastic. You know, we're talking about precision medicine, and I think as a profession, try to inch towards that, again, utopian goal. I think we got to first acknowledge that, you know, right now we're working with some pretty blunt instruments, right? You know, the whole struggle over the EGFR, I think reflects the challenge of us grappling with race as a variable that is so pervasive, and racism that's so pernicious. How do we integrate that into our care? I think true precision ultimately will not only be coming up with biochemical markers, molecular fingerprints of everyone, and understanding what their omics profile is, but it's going to take other data streams like the ones that Dr. McDougall just mentioned that really get into the social determinants and other less quote unquote hard measures for us to really understand what this particular patient or group of patients really need. The data streams, I think, ultimately are going to be multiple. They will include things like EHR, traditional work, but also I think there will be an increasing place for measures of people in the places that they live on an ongoing basis, granular data that may be collected not just year after year, but day after day for periods of time that give us new insights into how to best approach people's particular concerns. That day is not here yet, but I think it's on the horizon.
You know, if I think about reflecting on the pandemic, just coming out, hopefully out of this pandemic currently, I look back and I think about the fact that, you know, we were disproportionately affected, Black and Brown patients. And if you think about equity versus equality, equality would mean that everyone gets a vaccine. What we had to do is think about equity, which would mean not only do we have free vaccine for everybody, but we're thinking about outcomes. So trying to remove barriers. And we did get progress. If you look at Kaiser Family Foundation data, you know, there was movement. And currently, the folks who are most hesitant are not our Black and Brown communities anymore. There was a lot of work that was done to make sure that we remove some of those barriers to getting the free vaccine.
The EGFR race neutral approach is just the beginning steps at removing and addressing health disparities in nephrology care and kidney diseases. You know, even before the derivation of the EGFR equations, we already had documentations that there were disparities in kidney transplantation and the number of individuals who were of African American descent who were on dialysis. You know, and those disparities still exist today. And so, you know, with the intersect of cardiovascular health, we do know that African Americans have the highest rate of hypertension, which is a major risk factor for dialysis and kidney disease. And so in the EGFR approach isn't going to entirely address those disparities. So much work is really needed.
Thank you all for this really rich discussion. And I know we need to move to close soon. We do have some wonderful questions in the chat, but I did want to bring forth one question for Dr. McDougall, question about training for implicit bias for groups that face discrimination, and asking about intersectionality of race with other oppressed identities in terms of health outcomes.
So I mentioned the fact that the IATs include assessments other than race. So race, gender, sexual orientation, those would be 3 excellent IATs to start with, to speak to that intersectionality. Very good point. And so I'm in agreement with with the point that the questioner is making. Yes, we should engage across identities to help ensure improved outcomes. Thank you so much for that excellent question.
Thank you everyone for joining. Thank you again to the speakers and panelists, and thank you, Anne, for moderating. I know that some of you are trying to help answer the questions that are there. So thank you also for looking at the questions and taking some time to answer that, so folks who ask questions can get some answers. So we do want to make sure we do that. So the wonderful discussion today, the beginning of continued discussions, I'm sure, as Dr. Taylor was mentioning, a lot to cover in one short session. So really appreciate the start of this discussion. Just as a few logistical reminders, again, if you want CME and you didn't see at the beginning, you can use the QR code to register. You have to be registered to get the CME credit, or use the URL in the chat. Next slide. We are sending out a survey. It will pop up for you at the end of this. So please fill that out for us and give us some feedback on this and other topics for the future. And then there will be a separate, you can go to the next slide, there'll be a separate CME survey that also comes later. So there's 2 different surveys, one for CME and one just for our general feedback. There will be, this is just a notice of our upcoming webinar, Wednesday, May 25th, on remote monitoring and cardiovascular conditions, and Kathleen Dungan is serving as our keynote for that. More to come soon on that, but just an early notice for the next webinar. And just again, a thank you to everyone for joining with us and sharing this discussion with us today. And we'll remain on a minute or two for finalizing, but thank you again for everyone for attending.